So most respected doctors working in different COVID hospitals, and those who are in the team COVID management of government of Odisha. Today, we welcome all of you on behalf of the SCB Medical College to this virtual program on technical sessions. This is something different than we have been conducting for last few sessions on infection prevention control. Uh, to start with, we have taken a topic on COVID-19 and heart. You know, many of our patients are developing uh, myocarditis. Along with that, the ischemic heart disease, and those who have a pre-existing illness that deteriorate, increasing and aiding to the morbidity and mortality. And along with that, the pro-BNP becomes high in many patients. The troponin gets worsened in many patients, and not only the infection itself causes problem, but those who have a pre-existing illness, those who are diabetic, and those who are even not having a pre-existing illness have evidence of cardiac comorbidity. To tell us about the scenario, we have Professor Cardiology, Professor Eshan Rautre with us, who will start the session by telling that. Following that, we have a very interesting session on plasma therapy. You know, the plasma therapy is focused nowadays, and many are thinking it to be a very effective intervention in patients, and whatever doubt we had regarding efficacy, regarding the response of the patient, that has been solved in last 15 days after Honorable CM started the process in state on 15th of July. On 28th, we'll give you the SCB scenario and how exactly this becomes effective, so that the expanding numbers of plasma banks. You know, today Capital Hospital is starting its plasma bank. Then VIMSAR, MKCG, and the IGH will start their plasma bank. So there are almost 5 plasma bank planned in the state, and you'll know the scenario of plasma therapy. Many must have doubt regarding that. Then we have Dr. Khatui to speak about the newer molecules, especially antivirals. You know, the antivirals decrease the viral load and help patient recovering the battle. And we have molecules like favipiravir, remdesivir, even the oseltamivir and boosted lopinavir was once upon a time being promoted. So he has prepared covering the newer antivirals for all of you. And Professor Pani will be speaking you regarding the very important aspect of the uh, COVID care home, the personal protection, how you should move about, how what should be your mask, what should be your gloves, what should be your preparatory, the especially the doctors, paramedicals, they at the COVID care home. You know, COVID care home, the new concept started by state government, and we are going to train all the doctors attached to the COVID care home for this as well. And we are ending the session with a very interesting topic of dead body disposal. A lot of hue and cry, so there are existing guidelines regarding the emotional aspect, regarding the ritual aspect, regarding the safety aspect of the dead body disposal. We have Dr. Shikatanan who will be taking that topic with us regarding dead body disposal of a COVID-19 patients. So state government has given a recent guideline, you know, regarding how you should move about, and even pending the reports, the body can be handed over, and you can presume the patient, those who are in a suspicious scenario as a patient of COVID-19, and that can be disposed accordingly, keeping the family members safe at the same time respecting the sentiment and emotion of the people. We have with us Professor M.R. Patnaik, the person who has been working for all of you for so many times, for so many days. And Professor Patnaik will be there to start the program. And also he'll be taking all your queries at the end. Whatever comes, you please type your queries in the chat box. We are jotting it down. Dr. D. Pariza is there. He has already joined, and he will be answering directly in the chat box itself. to all the queries and give you links by which you can get connected to the website and take the information of the government. But those who need the attention of the panel at the end will take up. All our doctors, expert doctors from SCB Medical College will stay and quickly. Every presentation is around 12 to 15 minutes only. We don't have long presentations, so maybe in 1.5 hours we'll be able to take up the panel. Panel can take the questions and whatever things there in your mind, maybe related to today's topic, maybe beyond this topic in your day-to-day management also, because we are getting calls from every COVID hospital, different regarding different issues, regarding management issues. And I know today Rourkela people are asking about the plasma therapy. So many points are there, and expert panel is there to take up your questions. You know, today is a very big occasion. It's a World Hepatitis Day, and it's being celebrated everywhere amidst this COVID fear. And we are making awareness for everyone to become conscious. And you know, hepatitis is one of the dreaded disease which needs awareness and the vaccination. So on this special occasion, I wish all of you should stay safe and also take care of yourself, your family, your staff, and your people at your workplace. So Professor C.B.K. Mohanty, DMET sir, and Professor Rajadas, our additional DMET, have given their message to go ahead. They are in a Chief Minister's review regarding the COVID scenario. So without much delay, I request Professor Patnaik to just start the virtual webinar, and we'll move with Professor Rautray, the first presentation on COVID-19 and heart. Professor Patnaik.
Good afternoon, everybody. So, we have taken a lot of webinar classes regarding the infection control. Now the topics are different, and you must definitely enjoy all the topics. So first my question, where we are now? How will you contain the pandemic? So whatever the test we have got now, is it sufficient to contain the pandemic? So we have got RT-PCR. So with the RT-PCR, we are leaving another 40% of patients who are not diagnosed by RT-PCR. We have got also the rapid antigen test. So if you see, just I was analyzing the data of our hospitals. Till date, we have done 2,000 antigen tests. And is it out of 2,000 antigen tests, only 12 are positive. So that means whether the patient is there or patient is there, but we are unable to detect them. So the world is moving towards another test, another multiple test, which is very low cost and easily done without any technicality. So as you know, the pregnancy test, if the world can now create some stick test, which can be detected within 10 minutes, just putting in the body fluid and their color changes, then it will be available, then thing will be different. The MIT, Massachusetts Institute of Technology, they are working on that. The positivity rate is only 50%. That's why the FDA has not approved. They are working on that. If we can do that, we can get it. Any 2-3 days, if the test can be done on the same person, those persons are not detected with rapid antigen test or RT-PCR, which can be detected with this test. As you know, this virus rapidly multiply. Even within hours, they can go to peak. Suppose today, who is negative, test is negative, even if we repeat the test after 2 days, we can get it the positive. If you analyze the epidemiological data, out of 100% of patients, 70% they don't spread the disease. 20% patient are really super spreader. 10% patient only spread 1 to 2%. For each patient, there is spread is 1 to 2%. So actually the problem is this 20% super spreader. How to detect this 20% super spreader? If that is, we get the answer, and definitely if people will take their action isolation them, which is positive, then hopefully we can control. And as you know, 1% to 2% patients are coming seriously with other comorbidities like hypertension, cardiac disease. And thus, few days I was talking to Professor Rautai, can we get any markers which can detect early which patient are going for the thromboembolism? If from the beginning we get the answer, we'll be very cautious and take accordingly. You can save several deaths that occurring from the cardiac. So definitely this is a very interesting field, and I think the Professor Rauta definitely give an answer to this question, my query, and hopefully we'll definitely go ahead with this thing. I request Professor Rauta for his speech.
Uh, Thank you, Professor Patnaik. Good afternoon, everybody. Good afternoon, friends. Good afternoon, everybody. Our DMT, State Nodal Officer, friends. So, as Dr. Patnaik told now, actually, it's a new disease. All we are moving with hypothesis. The exact course is not known. So, when with this hypothesis, it's difficult to get the answer. And regarding this, there was a very important question he was asking on our way to Bhubaneswar. So if we can get the marker, which we can detect early, then we can get the answer so that we can start treatment early. We can prevent the problems that are arising. So for that, actually, only things that comes if we can get the inflammatory markers like interleukins and other inflammatory markers, they are the main things which are leading to this cytokine storm, and that is causing the problem. What I am going to tell, actually, this is not the atherosclerotic cardiovascular disease or heart disease. It is only the vasculitis and myocarditis that is the problem with COVID-19 and the heart. You see, as you all know, SARS coronavirus 2, that is COVID-19 virus because it is closely assembled with SARS coronavirus 1 that enter the cell through angiotensin converting enzyme 2. And there occur viral application and endothelial reticulum is affected. This is one of the important slides. You see on the left side, the SARS coronavirus mainly enter through the respiratory tract, go to the lungs, also go to the vessels, then go to the heart and other structures. In the second, you can see here from endothelial cells, then metabolic activity, all these things, there occur inflammation. Then they can affect directly the macrophage and immune system, CD206, 209 T cells, and that ultimately lead to the cytokine storm. These cytokine storm, they can affect the microvasculature, they can affect the macrovasculature, that lead to endothelial dysfunction and vasculitis. That destabilizes the plaque which is there in the coronary artery, that lead to acute coronary syndrome. Also, acute coronary syndrome can develop without involving the plug. This is by directly vasculitis, by this micro and macrovascular dysfunction. And here, if there is involvement of directly the myocardium, there can be myocarditis. All these things, this is myocardial dysfunction and damage that lead to acute coronary syndrome. These are affected. Acute coronary syndrome, two types. Type 1. Type 1 is that is the destabilization of the coronary plaque. That is less common here. More common, there is type 2. That is because of supply-demand mismatch. And the demand is more, the supply is less for the vasculitis and this vasospasm. And this vasculitis lead to thrombus formation, which is systemic thrombus formation in the arteries and also in the veins. This systemic thrombus formation that Dr. Patnaik are telling, if we can detect early which patient is going to develop this, then we can protect and prevent many case fatalities. But there is no definite marker to till now to detect this that we were searching. Then maybe one day we'll get. But ultimately, all this, then if there is in this involvement, there can lead to myocarditis and heart failure and arrhythmia. There are three major presentations: electrical instability or arrhythmia. If you see, if there is more of NT-proBNP increase, that lead to cardiac failure or cardiogenic shock. It ultimately go to cardiogenic shock. There is more of troponin elevated, then we cannot say whether it is due to supply-demand mismatch or it is due to the plaque destabilization. In that case, mostly it is supply-demand mismatch. But if there is a regional wall motion abnormality in the echo and regional changes in the ECG, we suspect this may be acute coronary syndrome due to coronary plaque instability. Actually, the initial stages of the disease in China, Italy, and US, many people have gone coronary angiogram. Most of the time it has come coronary angiogram is normal. That is why this is type 2, this coronary syndrome is more common. Regarding this myocarditis, again, this mainly because of the systemic inflammation and vasculitis. And this vasculitis can lead to arrhythmia along with your electrolyte imbalance. And involvement in the lungs results in hypoxemia that increases all these things. As you know, in pneumonia and influenza, there can be increased myocardial infarction. This is already known previously. These are the same things what I were telling, type 1, type 2 myocardium, but it can be easily said here. You see the three types of involvement, but immunopathology, hyperinflammation, and direct myocardial injury, or respiratory failure, hypoxemia, leading to the cardiac problem. The raised biomarkers, there can be arrhythmia, acute coronary syndrome, and heart failure, or leading to this cardiac shock. This interaction, as you know, it can be simplified. This patient present with hypotension, tachycardia, bradycardia, arrhythmia, or sudden cardiac death. This can be due to the binding of SARS coronavirus to the angiotensin converting enzyme, which is also expressed in the heart. Mostly in the lungs, also expressed in the heart. The increase in pro-inflammation cytokine and systemic inflammation, what we already told. And the other one, the suggested pathophysiology of significant cardiovascular disease common in the infected cohort. Patients with pre-existing cardiovascular disease are at a higher risk of adverse events of infectious and respiratory viruses. This viral infection may contribute to unstable chronic cardiovascular disease. This is mainly because of imbalance between the metabolic demand and the cardiac reserve. Who is at most risk of coronary bypass? This is one of the slides which everybody shows in any presentation, because this is the first time we came to know regarding this epidemiology. This is, you see, this age advances. This is from China, first study. Age advances, the mortality increases. But here again, this cardiovascular disease, the most common cause of death. Next is diabetes, next chronic respiratory, 10.5, 7.3, 6.3, hypertension itself, cancer, and others. But again, if you see in most common is, but this is because of the other comorbidities are also present in elderly. this elderly group is affected. But what happens in India? You see, India, many people are not insured, and hypertension out of 1,380 million people, 175 million men, 132 million are hypertensive. Cardiovascular disease is present in 78.67 million. COPD is quite large, 75 million people having COPD. The population of asthma is 45. And also here I can say the current smokers, they are also prone to develop severe problems. And the cancer, and the people with diabetes, 122.8 million. So all these things, you see, access to the facility is much less compared to other countries. This was one of the slides which came long ago. The type of death in India, 73% male affected, 27% female. They divided at that time below 40, 40 to 60, and above 60. Above 60, 63%. This is one of the recent data from here again. This you see, more than 15 to 29, less than 14, 15, 29, 30, 40. 30 to 75, you see here, this is the sharing of the population. Population is 35% below 14 years, mortality 0.5, and 15 to 29, the 18%. This is death 2.5. You see here, the most of the middle, that is 45 to 74, they are mainly affected. Here in India, above 45 compared to above 65 in Western population. That is because most of the comorbidities that commonly occur 10 to 15 years earlier, diabetes, hypertension, heart disease, all are 10 to 15 years, COPD, asthma, all are earlier in Indians. This is what shows, because Dr. Panda told that you must highlight hypertension. This hypertension, it says hypertension in its mortality 2.5 times more compared to the patients of COVID without any hypertension. This is, according to the studies till date, the most common comorbidity that is associated with COVID is hypertension. About 30%, diabetes about 20%, and CAD about 8%. But the frequency with which COVID-19 patients are hypertensive is not entirely surprising, nor does it necessarily imply a causal relationship, because hypertension is very prevalent in the world, in adults, and particularly in elderly. That is, since hypertension is exceedingly frequent and in elderly, in older people appear to be at particular risk of being infected by the virus. Okay, now. It is unclear whether uncontrolled blood pressure is a risk factor for acquiring COVID or not, but things are not in favor. Nevertheless, this question came whether to give ACE inhibitor and ARV, because the virus is entering the cell through angiotensin converting enzyme 2. Because one of the initial report and experimental animal, they found this by entering the cell through angiotensin converting enzyme 2, there occur off-regulation of the angiotensin converting enzyme in the blood. That's why this may be more affected if the patient is taking angiotensin converting enzyme inhibitors. But however, there are many studies after that, but none has proved to be related to this. You see, this is one of the important slides again we have seen. But if you see here, this angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. But angiotensin converting enzyme inhibitor blocks this. So when it blocks, then most of the angiotensin is diverted through angiotensin 2 here. You see, if it is this ACE inhibitor, angiotensin converting enzyme 2, you see, if it passes through this phase, these are pro-oxidant, pro-inflammatory, vasoconstriction, and pro-fibrosis, cause lung injury. However, if they pass through this pathway, when we give ACE inhibitor that blocks this pathway, is most of the angiotensin 1 go to angiotensin 1 to 7, they are beneficial. They are antioxidant, anti-inflammatory, vasodilation, anti-fibrosis, lung protection, and vascular protection. So actually, theoretically, to give angiotensin converting inhibitor or ARV, this can be protective to the lungs and heart. It has been seen in earlier studies before this that it's also protected to heart. So hypertension is an independent risk factor of COVID-19. Interestingly, ACE inhibitor and ARV may be associated with lower incidence and or improved outcome in patients with low respiratory infections. We also review the details of molecular mechanism linking reticular endothelial system to lung damage and the potential clinical impact of treatment with RAS blockers in patients with COVID-19 in a high cardiovascular renal risk. So, ACE inhibitor ARV, it has been shown ACE inhibitor and ARV increase the same angiotensin converting enzyme 2, which could theoretically increase the binding of SARS coronavirus to the lung and its pathophysiological effect leading to greater cell thought. However, it was found that these agents could actually contribute to reduce inflammation systemically, and particularly in the lungs, heart, and the kidney, by reducing either formation of angiotensin 2 in the case of ACE inhibitors, or by antagonizing the action of angiotensin 2 by blocking the AT1 receptors in case of ARV. So ACE inhibitor and ARV are theoretically helpful. These are the small studies which have shown that people have given ACE to ARV, those are not given. You see, this chances of death and severe disease is less those who are taking ACE inhibitor and ARV. Whereas this death and severe disease more those patients who are not given ACE inhibitor ARV. This is again a small study which shows the death rate. Those who are taking ACE inhibitor ARV are 3.7%, but those are not taking 9.8%. They are small studies, but that shows that again a positive relationship. This is a large study. The editorial which came inhibitors of renin-angiotensin aldosterone system in COVID-19. There are three large studies. One study 8,000 people from Asia and Europe, another 12,000 from New York, and 6,000 from Italy. They found there is no evidence that hypertension is related to outcome of COVID-19. This ACE inhibitor ARV use is harmful or that matter beneficial during the COVID-19 pandemic. They gave a balanced report. Use of these agents should be maintained for the control of blood pressure, and they should not be discontinued, at least on the basis of current evidence at this time. Basing on all these, this European Medical Agency and other professional societies say that ACE inhibitor ARV should be continued in patients of COVID-19 if it is indicated, and they should not be discontinued if they are taking. So coming to the management options, to simplify it, now we'll have to know that many of the patients of COVID-19 are going to be treated at home because this number of cases are increasing. Mild cases can be treated at home, this according to the central government circular, and now in Odisha also many people are being treated at home. So we all have to know how to treat these patients of COVID-19, those who have this problem, either hypertension or coronary disease. But I can say blanketly, there is no difference in the modalities of the treatment or the guidelines. Most of the guidelines, they agree that we might need to modify practice for standard cardiac patients, those who are suspected of COVID-19, and those patients with COVID-19. By modifying our cardiac care practice, we can save our patients, workforce, and help our society in challenging situations of COVID-19 pandemic. So if say, the recommendation is like this. If there is hypertension, patient is self-isolated, or hypertension is controlled, patient is staying at home, continue the treatment of antihypertensive medication according to the guidelines. Whatever guideline, because I have written an ESCES guideline, that's the most accepted guideline at present. Even our Indian guidelines is going parallel to ESC guideline. So it's you have to give either ACE inhibitor or ARV plus calcium channel blocker or diuretic as a first in a single pill. If they not controlled, then go for 3 drugs like ACE inhibitor or ARB plus and calcium channel blocker plus diuretic. So no need to adjust medication or stop ACE inhibitor or ARB because of COVID-19 pandemic. Very clear. Continue to monitor the blood pressure at home if possible. No need for routine clinical review at clinic during the COVID-19 pandemic. But if hospitalized hypertensive patient, unless there is hypotension or there is acute kidney injury, continue the treatment as the patient is continuing. No need to adjust the medications or stop ACE inhibitor ARB. So monitor for arrhythmia, which are more common in hypertensive patients and with patients with cardiac disease. Check for plasma potassium for hypokalemia, which is common in COVID-19. Parenteral antihypertensive medication will only rarely be necessary if the patient is ventilated and BP remains very high. So as for hypertension key message goes, there is currently no evidence demonstrating that prior treatment with ACE inhibitor or ARB increase the risk of COVID-19 infection. No change to these treatment recommendations is necessary during the COVID-19 pandemic. Self-isolated patients with treated hypertension should not need to attend the hospital for routine review visits. Antihypertensive therapy may need to be temporarily withdrawn in acutely ill patients in hospital who develop hypertension or acute kidney injury secondary to COVID. So hypertensive patient may be at increased risk of cardiac arrhythmia due to underlying cardiac disease. In patients previously treated for hypertension who require invasive ventilation, parenteral antihypertensive may be required. Treatment of hypertension should follow existing recommendations or guidelines. Patients could make use of periodic home BP monitoring with video conferencing or phone consultation. Then from chronic ischemic heart disease, now it is called chronic coronary syndrome or CCS. So continue the medications of CCS patients is recommended during COVID-19. Follow-up CCS patients via telehealth, no need to attend the hospital because they are chronic, they are stable. Revascularization for severe CCS patients must be postponed in low to intermediate risk. That time point. Patients low or intermediate risk need only medical management. Postponing to non-invasive testing in CCS patients should be considered during COVID-19. CT angio may be helpful. So, if the patient is going for any surgery, they should be, as usual, they should go for nasopharyngeal swab and CT scan. Revascularization for high-risk coronary syndrome patients may be considered during COVID-19 patient if patient with high risk of symptom and or coronary anatomy and a large ischemia assessed by the heart team. The heart team constitutes cardiothoracic surgeon, one interventional cardiologist, one non-interventional cardiologist, and family members. And this PCI may be considered over CABG because this contact time is less in PCI, contact time is more in CABG, in OT time is more, and to shorten the hospital stay, and the beds should be available of the COVID-19 patients. And here, this identification of non-COVID hospital may be considered as a hub for cardiac surgery, or you can say PCI. This invasive management of chronic coronary syndrome in COVID-19 positive patients should be deferred until the patient is recovered whenever possible. So the practical consideration for chronic coronary syndrome, NSAID have been identified as a potential risk factor for serious clinical presentations. A low dose aspirin has very limited anti-inflammatory effect. Therefore, chronic coronary syndrome patients should not withdraw aspirin for secondary prevention. And sometimes statin has come controversy, but statin is always useful, has been very well associated with favorable outcome in patients admitted with influenza and pneumonia, even when there is CCS is not there. So statins and aspirin have to be continued. So this is a flow chart. I think I can just say if there is low risk, then non-invasive testing. If intermediate risk, go for non-invasive testing. If there is high risk or very high risk, they should be treated as acute ST elevated myocardial infarction. Or there is high risk, they should be investigated, early invasive strategy may be considered. So key message, very high risk anesthesia should be managed similar to STEMI. High risk STEMI SCS should be tested before coronary angio. Intermediate risk should be evaluated non-invasively. Consider adding CT coronary angio protocol to thoracic CT scan, which is performed to COVID-19 patient. At the same time, they can give information regarding the involvement of the coronary artery. Regarding STEMI patients, this is very simple because if the patient comes, only thing helpful in this setting is primary PCI. If the patient is reaching the hospital where is PCI capable and PCI can be performed within 24 hours, then he should be offered primary PCI. Otherwise, if it is not possible, they should go for fibrinolysis. It is not in COVID, if not in presenting to a hospital where this PCI facility is not there, then go for fibrinolysis. And if primary PCI is feasible, the hospital is nearby, patient is capable, and then patient can send for primary PCI. Only thing helpful primary PCI, that is acute mitral infarction if they are intervening within 24 hours. So all STEMI patients should be managed as COVID-19. This is highly suspect. Primary PCI, the first line of therapy, if it can be performed in a timely fashion within 120 minutes of symptom onset, but benefit is there up to 24 hours. Fibrinolysis, if not contraindicated, can be considered when there is delay is longer. Always fibrinolysis, most of the patients will need fibrinolysis. Complete revascularization to be considered if indicated appropriate. Otherwise, only target vessel. Left ventricular angiogram instead of echo, because echo in COVID patients, because of this myocarditis, they give a false regional wall motion abnormality picture. Acute heart failure, actually all acute heart failure, this should be treated as acute heart failure whether COVID positive or not. The underlying mechanism of acute heart failure may include here, as we discussed, acute myocardial ischemia, infarction or inflammation, ARDS, acute kidney injury. So COVID-19 pneumonia will lead to worsening of hemodynamic status. Clinical presentation of pre-existing cardiovascular morbidities and chest imaging findings suggest heart failure, like cardiomegaly, valvular lesion, etc. The same treatment strategy for acute heart failure can be applied for patients without COVID-19. So, for chronic heart failure, the risk of COVID-19 infection may be higher in chronic heart failure patients due to advanced age and presence of several comorbidities. However, by doing this ECG, this echo, X-ray test, we can diagnose. This ambulatory stable heart failure patient should be refrained from hospital visit. Guideline-directed medical therapy like beta blocker, ACE inhibitor, ARB, or ARNI can be offered. The telemedicine should be considered whenever possible to provide medical advice and follow up to stable heart failure patients. So to summarize, the treatment protocol for COVID positive or negative is same. Only thing, we'll have to give patients the proper care. And this slide I intentionally kept because this two of the antiviral agents, lopinavir and azacitidine, has been found to have some interaction with some of the ARBs like irbesartan, losartan, and valsartan. But most of the people who are using this enalapril, lisinopril, perindopril, ramipril, telmisartan, and olmesartan, there is no reaction. Well, again, ARNI, because valsartan is there, that is also reaction. Eplerenone is important because eplerenone is showing it is co-administration must be avoided, it's contraindicated. That is spironolactone is given. Here again, CCB, you see, amlodipine, diltiazem, nifedipine, all these things are here potential interaction between lopinavir and this is atazapine. Here again, the same thing you see, clopidogrel, ticagrelor, they are the same two drugs. But aspirin is quite safe. Fasudrel has been found to be safe in the evidence. Since enoxaparin and fondaparinose are safe, warfarin has some reaction. Again, NOACs is again these two agents, but others they are not so commonly used. So with this, we can say the involvement of the heart is actually not more. According to the prevalence, there people are elderly. In India, the comorbidities come earlier diabetes, hypertension, they come earlier. That's why it appears the prevalence is high. However, if affected, if infected, the chances of prognosis is bad. The chances of mortality is high unless treated properly. Thank you.
Thank you, sir. It was a nice presentation covering coronary artery disease, covering the heart failure, covering the hypertension, and also the related problems like drug therapy, different drugs. So I think Professor Rautra has overall covered all the issues related to heart and also how the virus goes with the heart cardiac patients. So I request sir to just stay with us for some time, and we'll take up the questions quickly finishing.
Yes, sure, sir. Many of the things are not covered. People may ask in the next.
Yes. Other modules.
Yeah. Thank you.
So immediately we'll go to the next topic, the plasma therapy. And the plasma therapy has created interest among the patient's family, and also the doctor around, not only in Odisha, in the country, and all over the globe. And the topic which we have kept for today, that many are hopeful that this will save our patients when we don't have adequate interventions in the form of medicines, in the form of antivirals, in the form of vaccine, and helplessly we're trying to stop the virus, and the numbers are going high day by day. The death is increasing, and many and those who were very stable initially are gradually becoming hopeless, thinking that we are getting defeated to the virus. So in that time, Odisha has started plasma therapy. Long back in SCB Medical College, we had proposed government of Odisha to start plasma therapy, but at that time there are some views against plasma therapy also, that this can cause more harm than good because the immunity generated by the virus was not clear. So ICMR didn't give not to many centers, including one of them was Odisha. But in last 2 weeks, we have seen good outcome in Odisha. I'll tell you, especially SCB experience. And today, as I had told at the beginning, we are starting the plasma bank in Capital Hospital, followed by at Bhimsar, at MKCG, at IGH, Raurkela, and the government has a dream of popularizing this, appealing all the people who have got good care and recovered, saving their own life from this dreaded disease, are requested to donate and help people who are fighting for life. So let us see in next 10-12 minutes what is this and how this works. The whole world is burning with COVID-19, and to date we have 1,66 lakh odd patients in the world, with death which has crossed 6.5 lakhs, and country is approaching total number of 15 lakh patients, and death is almost around 33 and half thousand. Odisha is approaching a number of 30,000, with deaths crossing 150 today. So with this scenario, let us see that what is plasma therapy in COVID-19. These are a few photographs how SCB started plasma therapy. 15th of July, Honorable CM has started the ball rolling, and the first recipient was on the same night only at Oswini Hospital, and she has recovered and discharged by now. So there are no approved treatments, there are no vaccine. The management plan is supportive care with supplemental oxygen and mechanical ventilation. So US FDA has recently approved the plasma therapy, and from the people who recovered from COVID-19 for the treatment of severe or life-threatening COVID-19 infections. And historically, we know that this plasma therapy is used in the viral diseases like poliomyelitis, measles, mumps, influenza, where vaccines were not available, because the basic concept is we are passively infusing the antibodies. Its use in saving lives from Zika and Ebola viral infections we have seen in the past. The MERS and SARS, as well as swine flu, and around a century back, the Spanish flu pandemic was the occasions where the plasma therapy was used, and with benefit. The convalescent plasma therapy aims at using antibodies from the blood of a recovered COVID-19 patients to treat those critically affected by the virus. The therapy can also be used to immunize those at a high risk of contracting the virus. Whereas this is another side, somebody has not contracted, and prophylactically, such as health workers, families of patients, other high risk contacts can also get immunity, passive immunity by plasma therapy. This therapy's concept is simple and is based on the fact that the blood of a patient who has recovered from COVID-19 contains antibodies with the specific ability of fighting novel coronavirus. And the theory is that the recovered patient's antibodies, once infused into somebody under treatment, will begin targeting and fighting the novel coronavirus in the second patient. And the convalescent plasma therapy is akin to passive immunization, and many researchers tell it's a preventive measure and not a treatment for COVID-19 disease. So, donor eligibility, what are the whom we consider fit to donate the plasma? First, prior diagnosis of COVID-19 documented by a laboratory test. He must be a positive patient, and complete resolution of symptoms and at least one negative lab report as a PCR from a government recognized laboratory or COVID-19 before 28 days prior for COVID-19, before 28 days prior to donation. So 4 weeks must have spent after recovery of the patient. At the peak time, the antibody is formed, and these individuals will be contacted telephonically when there is a need of his or her plasma, and explain the details. A routine informed consent to be procured when they come for the donation, and they will be encouraged to visit the blood bank for further evaluation towards the eligibility for blood donation. And if requested, they will be provided transport for the same. And only male and nulliparous female donors of weight more than 55 kg will be included, because those who are pregnant even once, not now, even they have been pregnant even once, they have actually antibodies which target the long basement membrane, and the ladies with history of pregnancy are not encouraged to donate plasma, and not fit for donating. And donor eligibility criteria for the whole blood donation as per the departmental SOP will be followed according to the Drug and Cosmetic Act 40 and 1945 and amended March 20. The recipients, hospitalized COVID-19 patients admitted for care at COVID-19 management facility, will be given convalescent plasma therapy. Admitted with RT-PCR confirmed COVID-19 illness as more than 18 years, and a written informed consent must have been given to receive the plasma. And the most appropriate people are PO2 FiO2 ratio less than 300, respiratory rate more than 24 per minute, and saturation less than 93% on room air. So these are the people whom considered appropriate for the plasma therapy. But we remember those who go to shock, that mean arterial pressure less than 65, and also the PO2 FiO2 ratio less than 200 are taken as unfit for the donation. So pregnant women, breastfeeding women, known hypersensitivity to blood products, receipt of pooled immunoglobulin in last 30 days, and critically ill patients with the PO2 FiO2 ratio less than 200, that's moderate to severe ARDS, shock requiring vasopressor to maintain MARC 65, they are excluded, they're not given. Clinical status precluding infusion of blood product are taken into consideration before the transfusion. These are the adverse effects. They are usually minor. Majority adverse effects associated are non-lethal, medically treatable, and adverse effects commonly associated are the transfusion-associated reactions, circulatory overload, the allergic and anaphylactic reactions, transfusion-related transmission of infections, the febrile non-hemolytic transfusion reactions, hemolytic transfusion reactions, the RBC alloimmunization, and other theoretical risks are antibody-dependent enhancement of infection, and usually the convalescent plasma therapy is given here as an off-label treatment, which may improve the clinical outcome in patients with COVID-19 infection. So these minor effects can be contained at our end. So I'll quote now what the world evidence shows. This is a Chinese journal. They had the first publication regarding the effectiveness of the convalescent plasma therapy in severe COVID-19 patients, where they had taken just 10 patients, and the severe patients confirmed by RT-PCR, and one dose of 200 ml convalescent plasma derived from the recently recovered donor's neutralizing antibody was given, and they were seen for the antibody titer as well, and the lymphocyte counts, the radiological examinations, and the conclusion was the convalescent plasma therapy was well tolerated, could potentially improve the clinical outcome through neutralizing the viremia in severe COVID-19 cases, and the optimal dose and the time point, as well as the clinical benefit of therapy needs further investigation they had promoted. So let us see this publication in the American Journal of Pathology, which is also a very thorough paper I came across. And this American Journal of Pathology has also given a very concrete experience of the use, and the patients enrolled at Houston Methodist Hospital from March to April, transfused with convalescent plasma obtained from donors who confirmed severe acute respiratory syndrome infections who had recovered. Primary study outcome was safety, and then secondary outcome was the clinical status at day 14 after transfusion. Usually till 28 days the patients are followed up regarding their reactions, early reactions, late reactions, and their in general health status, and this shows almost minor reactions, and except 1 to 2%, everyone have recovered after the plasma therapy. This is transfusion and apheresis science, which was again published during this time, and this again concludes the quick improvement of the people not requiring oxygen therapy, and patients were stabilized without any fever and hypoxia, and discharged in a 4 to 7 days time from the hospital after convalescent plasma therapy. So these are three important papers under the latest publication in Indian Society of Transfusion Medicine, the Asian Journal of Transfusion Science, tells a clear positive experience about the therapy. So after that, the SCB experience, I'll tell you, till date, we have received 42 units of plasma from 21 donors. Usually the donors are taken as the patient who have recovered from the disease, and each donor give around 400 ml. Two plasma are collected from each donor. So we have 42 units collected, and to till date, Ashwini Hospital has received 8 units, Sham 6 units, 10 units, Teams and 9 units has gone to Ganjam, and 1 unit to Rourkela today. And the summary I'll tell, most of the patient whom this plasma has been transfused, they have on the day 3, they have the oxygen requirement has come down, and day 5 to 6 they have gone to ward, and maybe in a day or two they are discharged. Already 7 patients out of this 34 received are discharged by now. The rest of the patients are, majority patients are stable. Only 3 have not shown any difference in their outcome, and they are still being treated. And 2 patients are lost after 4 days and after 8 days of treatment because of problems related to the cardiac complications and other complications because of complications not related to the plasma transfusion. So that shows a very good initial experience, and I'm sure with all other plasma banks coming together, we can have still better experience with us. So this is the concluding slide, where the plasma has been very encouraging in the state, to the effect that many patients from their side insisting therapy to the doctors and to the known people. And there's a new hope, and government has also taken steps to make it widely available and appealed all those who have recovered to donate plasma. So to summarize, this is a therapy which is not new for us. Almost 126 years back, the therapy started. It has been given in many pandemics, including SARS, MERS, swine flu, Ebola, Zika, as well as the Spanish flu. And many positive outcomes have been seen from this therapy. And if you see the present experience of 2 weeks, in just 30 odd units of plasma, we have saved many lives, and people have not only recovered, decreased oxygen requirement, and positive outcome has changed the scenario. And the evidence next review will be telling you the analysis of the initial data which has been done, and this is about the basic uh, procedures, eligibility, and methods of exclusion, and the SCB experience. So thank you everyone for the time. With this, we'll go to the next presentation. That's by Dr. Thartoi, who will be speaking about the new antivirals. You know, like plasma therapy, the newer antivirals have brought hope, and those who are critically sick patients, and timely we started with drugs like favipiravir and remdesivir. They started responding, and government also didn't leave any stone unturned, and Odisha made everything available to the COVID hospitals, and those who are sick are receiving also high-end medicines like tocilizumab, the interleukin 6 inhibitor, are being given. The antivirals are being given. So the latest antivirals need to be discussed. So I invite Dr. P.K. Thartoi to tell us about the drugs, and really how they work, and what is the risk in using, and how we can expect many more antivirals in the pipeline to come in future. And Dr. P.K. Thartoi.
Oh.
Okay. So, good afternoon, all the viewers. This is the topic: newer antivirals in management of sick coronavirus disease 2019. And okay, so topic is important. This is not the magical drug. Like if somebody is having typhoid and will give anti-typhoid treatment, patient will cure. Patient will cure. So there are many controversies, as you know. There were some antivirals also. Like when COVID came, people have started using oseltamivir. So gradually they stop it. Oseltamivir has no role in COVID. It is in swine flu or the flu antiviral drug. Next, people design
that this is one on anti no, ART or anti-HIV drug which cures coronavirus, that is lopinavir and ritonavir. Then came these drugs are not beneficial. So now people are stopped using lopinavir, ritonavir. Lopinavir and ritonavir no way in treatment of COVID. So next comes one drug, that is remdesivir. Yes, trial is going on. Remdesivir helping data shows some are data against its efficacy. So the RCT randomized control trial is still on WHO funded trial. So we'll expect another 2-3 months to say remdesivir's efficacy. That's better. In between, another new drug came in COVID. This is not new. This is an antiviral drug used in flu patient, that is favipiravir. So I will point out something on favipiravir. Favipiravir, when to use and when not to use, and better not to use. So there is recently went through a trial, Bangladesh randomized control trial, Dhaka trial, completed in this month, July. So this is experimental favipiravir for standard treatment. That is favipiravir 200 milligram tablets will be given orally day 1. And tablet favipiravir given, the doses are very high doses. Day 1, they have given 30 to 100 milligram. That means 1600 milligram twice daily. Then day 2 started 2 to 10 days. Then first day 30 to 100. Then 600 milligram twice daily for 10 days. So very high dose. Believe me, favipiravir tablets available, only 200 milligram tablets. Our recommendation is 1200 milligram to 1800 milligram. Not possible to swallow 8 or 10 tablets at a time. It's very difficult. One. And placebo comparator, only standard treatment, and the standard protocol included oxygen inhalation, oral or intravenous rehydration, electrolyte correction, antibiotics, all those analgesics, antibiotics. So medication of any patient due to any concomitant diseases going on, that's all. And the number were very less. They have taken 25 patients and versus 25 placebo. And they found virus clearance by day 4 was only 48% in the treatment arm, and by day 10 it is 96%. And they have given not in serious patients, only mild and moderate symptoms. 44% were lung clearance than those on placebo, and lung function improved 3 times more than placebo in this mild or moderate group of patients. Second, another RCT going on US and UK. This is open label trials in Europe, particularly France, in Turkey, Iran. It is expected to be complete in 2021. So this trial is going on. So the mechanism of action of favipiravir is this inhibits the RNA polymerase enzyme. So it inhibits the replication of the virus. But and another trial, this was published in Critical Care Medicine Journal, CCM Journal. They have given favipiravir, and they have added also favipiravir with steroid, dexamethasone. With the effect of dexamethasone, this interleukin value decrease. So this is not purely by favipiravir. So Indian studies just completed. There is no RCT in Indian study, no randomized control trial, no neck and neck trial, just some anecdotal data, and data are properly not available, done in mild patients. None with these patients who are not with NIV, ICU or pregnancy. They have given in just ward patients on OPD basis. Many open level trials are going. So efficacy in India is still in doubt. So we should not think that favipiravir is very wonderful drug and will cure the COVID patients thing. What is the data so far? Russia, Japan, and India open label trial studies. There is no RCT trial. So obsolete comparators. Unknown if natural history of viral clearance is accelerated. Perhaps if RT-PCR test negative faster can conclude quarantine sooner, but not in any guidelines. Okay, this can help that it can clear COVID sooner, so that quarantine period, it may help that quarantine period may be sooner. That is the thing. Will it impact antibody formation? It's a big question. And with this favipiravir treatment, there is a lot of side effects which may be mild. So uric acid elevation, hyperuricemia is one important side effect with some GI symptoms, particularly diarrhea. Maybe there is chance of QT prolongation. Bradycardia, the anecdotal data, and teratogenic cannot be given in pregnancy. On conclusion, should we use it? We have to think of that because of its cost. We have to consume per day 1200 milligram to 1800 milligram tablet. Costly. Benefit unclear, perhaps similar to influenza treatment. Await data which should come out soon. There is no RCT going on in India or world on favipiravir. If you want to see, please review those. It is a lot of pills to swallow. That's the thing. Next comes another new drug, remdesivir. It is not new. It has been used in Ebola. In Ebola, it's a promising drug. It helped, it controlled. In swine flu, remdesivir, it inhibits the viral RNA-dependent RNA polymerase enzyme, so it prevents the replication of enzyme. In vitro, remdesivir inhibited the replication of SARS coronavirus 2. The investigational drug, this investigation is going on. The WHO funded RCT trial. In one arm, they are using remdesivir, another arm, they are using conventional drugs. Manufacturer is a Gilead US company. Ongoing research going on. Criteria to give in remdesivir, the person should be SARS coronavirus proved positive, RT-PCR positive patient. If patient is negative and signs of corona is SARS corona is there, it's not recommended till that. Hospitalized patients with severe coronavirus COVID-19 proved patient, and patient should have SpO2 or his oxygenation should be less than 94% on room air, requiring supplemental oxygen, requiring mechanical ventilation, or requiring ECMO, or patient, in a broad sense, we say patient, sick patient admitted in ICU. eGFR has to be greater than 30 ml per minute. Established CKD grade 4 and grade 5 should not be given. And one important contraindication is AST-ALT should not be more than 5 times of upper normal limit. Discontinuation of remdesivir, if remdesivir someone is giving at the time when he should not give remdesivir, this time are ALT or enzyme, liver enzyme greater than or equal to 5 times of upper normal limit during treatment with remdesivir. Remdesivir may be restarted when ALT is less than 5 times of the upper lower limit. By discontinuation, if the enzyme comes down, then one can think of restarting. ALT elevation accomplished by signs or symptoms of liver inflammation or increased conjugated bilirubin alkaline phosphatase or INR. Hypersensitivity reaction is there. If there, should not give. eGFR less than 30 ml per minute should not be given. So there are some established side effects of remdesivir: liver enzyme elevation, GI disturbances, infusion reaction like nausea, vomiting, a low blood pressure, or hypertension, which is more common than GI disturbance. Ongoing research for other side effects is going on. The take-home message is that it is shortening time to recover in adult hospitalized patients in COVID-19. Timing of starting the drug is important. Delay in starting probability is less. So this is the drug after giving steroids, particularly dexamethasone and enoxaparin. The third thing in sick patient can be added remdesivir. Thank you very much.
Thank you, Dr. Khatri. That was a complete disposal on the newer drugs. He has told how difficult to take 8 tablets twice a day, day 1 and 3 tablets maybe up to 10 days, favipiravir. And the drug is nephrotoxic. It has been shown that if patient is not very sound renal function wise, it can precipitate AKI and patient may require hemodialysis also. But remdesivir injectable we are giving to the sick patients, and as Dr. Thakur has concluded, in coming days we can be very sure about the safety and efficacy of these antiviral drugs. So we'll take up the questions at hand. Now the most awaited session by Professor Nivedita Pani. It's about your own personal protection. The doctors at COVID care home must be wanting that whether the mask they have put is adequate enough to protect them from the virus or not, because you are the people who are facing the positive patient, and a little carelessness can infect you, can expose you to a dreaded situation. So, ma'am will tell you regarding the personal protection at COVID care home. Mr. Nivedita Pani.
Thank you, Professor Jayan, for that. I'm going to discuss about the IPC for the healthcare worker who are working in the COVID care homes. So the Odisha government recently has announced that these COVID care homes were in the Gram Panchayat or in the urban areas. So how many Gram Panchayat has been taken? Nearly 6,798 Gram Panchayat has been taken, and the facilities will be given 10 to 20% in one COVID care home. How much they will accommodate? 70,000 people. Whom they will accommodate? Those who are having the symptoms of cold, cough and fever. Who will supervise? The multi-purpose health supervisor. And who will be in the administrative management? The non-medical logistic by the Panchayat Raj members, and it is also run by the help of ward member, ANMs, ASA worker and members of the local women's health group, and the trained unemployed ANMs with registration. If not available, then unemployment staff nurses and pharmacists with registration of the district will be engaged. Then what you should do? All person with flu-like symptoms, they will brought to the COVID care home, and they will be isolated from the community pending COVID test. Then the test will be done. What will happen? If the test is negative, they will return to their home and advised home quarantine till the symptoms subsides. And if positive, they will move to the COVID treatment facility, as we have already discussed. Then who will do all these things? In the village level committees in rural area and ward level committees in the urban area, they will monitor the health condition and bring those symptoms to the one happen. All these symptoms, then they will bring to the COVID care homes. What are the equipments required for this? Because it is a COVID care home, it's not a big hospital. So minimum things what we require is an infrared thermometer, BP instrument, stethoscope, glucometer, heuristic and pulse oximeter. And let's come to my topic. So in the COVID care, should observe infection prevention practice strictly. And because all the cases, they may be potentially COVID positive cases. So they should wear appropriate PPEs, have access to N95 mask wherever required, soap and water. What is the things will be done? Once the admission is done, then the detailed history will be by the health worker. Preliminary examination of the temperature, heart rate, respiratory rate, BP and oxygen saturation. Then next will be lab confirmation. If the COVID-19 positive, then shift to the appropriate facility. Who are the vulnerable group for which consideration to be taken care, and they should be segregated and should be tested on the priority basis. If she is pregnant, age less than 5 or more than 60, comorbidities like diabetes mellitus, hypertension, kidney disease and asthma. Then these are the component: IPC for facility, healthcare worker, for patient, visitors, training and monitoring. So IPC for the facility, we take care is the environmental decontamination, cleaning of the medical equipment, cleaning of the soil bedding, towels, clothes, cleaning and disinfection of the occupied patient room, cleaning and disinfection after patient discharge and transfer, and prevent environmental contamination, which contains the respiratory secretion and biomedical waste management. So what is the IPC for the facility? Build a fence to prevent animal entering the facility. Train security personnel 24/7 rotation, and plan your facility well. Which area in this COVID care home? Triage area, COVID wards, duty rooms, entry and exit point. All this facility will be disinfected daily with freshly prepared 1% hypochlorite detergent solution. What they will include? Mopping the floor, cleaning the bathroom, toilet, underside of the beds, other item placed in the rooms of the COVID care home. In the COVID care home, you know there is environmental decontamination we have to do. In the housekeeping surface divided into two types. One is a minimum hand contact like floors and ceilings, and high touch surface like doorknobs, bed rails, light switches, wall area around the toilet of the patient room, and edges of the private curtains. So how we'll do the decontamination? As we have told earlier, the 3-bucket system. First you mop with warm water and detergent solution. After mopping, clean the mop in plain water. Then second, mop the area using 1% sodium hypochlorite, protecting electrical points and appliances. Then cleaning with the neutral detergent for removing the traces of hypochlorite solution. And how you do the equipment decontamination? When you do the equipment decontamination, wear the gloves. Possible, use disposable or dedicated equipment, but for in our state it is very difficult to use the disposable like stethoscope, BP, cough, thermometer. So what we'll do? We have to decontaminate it. So before removing the equipment from the patient room, medical equipment must be disinfected. If sharing equipment between the patient, clean and disinfect between each use. So if the instrument have got the manufacturer instruction for the decontamination, you can do it. If it is nothing is written or you don't find anything, you can decontamination with ethyl alcohol 60 to 90% or isopropyl alcohol 60 to 90%. Alcohol causes discoloration, swelling, hardening of cracking of the rubber. So you have to take care. And stethoscope, as I have told you, cleaning by detergent, water and alcohol. BP cups, same with the alcohol-based disinfectant. Thermometer with the tepid water and detergent and alcohol rub. Then injection and dressing trolley to be cleaned daily with the detergent water, and after each use wiped with disinfectant. Next come, you are handling the patient, you do not know they are positive or negative, so you are the appropriate PPE, heavy duty. When you are doing the linen decontamination, what do you mean by the linen decontamination? Like the soil bedding, towel, clothes. So that time wear the appropriate PPE, heavy duty gloves, mask, eye protection, like goggles, face shield, long sleeve gown, apron, and boots and closed shoes. Never carry the soiled linen against your body, and always place the soiled linen in a leak-proof bag or bucket, and perform the hand hygiene after the blood and body fluid exposure or after PPE removal. Clean the laundry surface at least once a day or when a patient is discharged. And pillow, mattress, linen should be first treated with 1% hypochlorite spray. As you know, we have told earlier, if washing machine you are using, then hot water cycle 90 degrees centigrade, wash with detergent, then soak with 0.1% sodium hypochlorite for 30 minutes and dry. If no machine washing, then soaked in hot water, soap detergent, use a stick to stir, empty the drum, then soak with 0.1% sodium hypochlorite for 30 minutes, rinse with clean water, dry both sides, sunlight for 3 hours. And the soiled textile, including bedding, towel, and patient or resident clothing, while using, you have to be very careful. Don't shake it because it will aerosolize infection agent. Avoid contact of one's bodies and personal clothing with the soiled items being handled. And soiled items, you put it in a laundry bag or a designated bin. And clean item, once it is the things are being cleaned, it must be packaged or completely covered and placed in an enclosed space. Then next comes when the patient will eat, what you will do? All this eating utensil, what should you do? You clean with hot water and detergent, and vessels that are being used for COVID patients should not be shared, and better you use a disposable product may be used. If possible, use biodegradable disposable cutlery. Then spill management, clean the spills, should be wear gloves and other personal protective equipment. Use the disinfectant hypochlorite 1% for the small spills and 10% for the large spills. And as you know, all the health workers should properly train to use PPE or assisted during wearing, and separate areas should be earmarked for donning and doffing. And don't touch your eyes, nose or mouth with gloves or bare hands until proper hand hygiene has been performed. If you start coughing, sneezing or develop fever after you have provided care to this patient, report your illness immediately to the concerned authority and follow their advice. Next comes how to transition between home and work. Means yourself. Means you should keep a 2 to 3 set of dedicated clothing of work. What you should wear? Simple clothing like short sleeve shirt, pants of short sleeve salwars, without dupatta or a short dupatta, or a cheap old dedicated work shoes or sandals. If wearing sari, keep the pallu shut and tuck it into your hip. Avoid belt, jewelry and ID card. Hot wash and dry cloth daily. Wear cloth mask when you are traveling on two-wheelers or in the public transport. How to transition between the home and work? Avoid carrying a bag or backpack. Get a stock of sellable plastic covers. Leave wallet at home. Bring essential like key, ID card, driver's license, bank card in sellable plastic bag. Keep your phone in your pocket bag. Avoid placing it on the work surface. Leave it on a loud volume. Wipe phone down between each use. Keep your keys in your pocket or bag and don't remove until after you have washed hand when leaving work. At work, appropriate PPE as per need, regular hand washing and use of alcohol-based sanitizer, avoid touching mask, nose, mouth or eyes, and food and drink, bring lunch from home in reusable cloth bag which you can wash daily, use own water bottle, avoid bought lunches from outside water coolers or common refrigerator. And before leaving work, leave the pen at work, frequently coat it with alcohol hand rub throughout the day. Avoid touching surface unless necessary. Leave the doors open if possible or use feet or hips to open the doors instead of using the door handles. When leaving work, proper doffing of the PPE. Remove the work clothes and place it in a plastic bag to take home. Perform thorough hand and warmers. Sterilize your mobile phones, key, glasses, accessories. You'll bring back home alcohol 70%. Keep alcohol hand rub either in your bag or in your vehicle. And after arriving, just avoid hugs, kisses, direct contact with family members until after shower or a bath and wash. Remove soles, leave outside before entering home. Remove work clothes at front door. Put this hot water with detergent, reusable cloth lunch bag, and immediately you have hot shower, bath and wash. And what is the IPC for the patient? Suspects patient and confirmed patient after test before transferring should be kept in a separate room. Maintain at least 1 meter distance between all patients. Limit the movement of the patient. Maintain good ventilation. Patient should wear triple layer mask. And the respiratory hygiene and cough etiquette which you are repeatedly telling, cover the nose, mouth when coughing or sneezing. Use tissue to contain respiratory secretion. Disposable of the tissues in no-touch receptacles like waste container with foot-operated lid or uncovered waste container. Perform hand hygiene after contact with the respiratory secretion and contaminated object or material with alcohol-based hand rub or soap after water. IPC for the visitors. Limit the number of the visitors per patient up to 1. All visitors wear the appropriate personal protective equipment and visits should be recorded or should be minimized. And IPC training, all patient attendant visitors should be given basic information regarding the hand hygiene, social distancing, wearing of the mask, infection transmission, and steps to mitigate them. IPC monitoring, who will monitor? The healthcare worker posted in the COVID care home are responsible for the proper IPC practice in the facility. This can be monitored by the concerned sector medical officer or local administration during the periodic visit. How do you dispose the medical bags? General solid waste like waste generated from the kitchen, packaging material, waste food material, waste papers, waste plastics, floor cleaning dust, leftover food, all these water bottles, Tetra packs, they use suspected person at COVID care home. What you should do? You should collect in bags, securely tied and handed over to the municipal solid waste collector, identified the urban local bodies in the urban area and in rural area to the designated BMW collector for final disposal. And the use mask, glove, tissues or swabs, contaminated blood and body fluid, including use medicines, if generated, should be treated as biomedical waste. So it should be collected, as you know, in yellow bags, and you should be provided by the urban local bodies or in rural area by the designated BMW handler. These bags can be placed at dedicated dustbins, and inner and outer source of the container, bins and trolleys should be disinfected with 1% sodium hypochlorite, and mandatory leveling should be there, COVID-19 waste. And hand over these yellow bags are containing biomedical waste to authorized waste collector or doorsteps engaged by the local body, or hand over to the biomedical waste to the waste collector engaged by the common bio waste treatment facility operator at the doorstep. Person, suppose you are seeing, you are finding any problem in the COVID care home that your biomedical disposal is not properly done, then report to the urban local bodies or local authority in case of any difficulty in getting the services for disposal of the solid waste or the biomedical waste. So as we have told earlier by my previous speakers, yellow like human anatomical waste, anatomical animal waste, and all microbiotech clinical lab waste, red for the contaminated waste, white for the waste. We are telling this, blue for the glassware waste. You follow this principle. To conclude, cleaning and disinfection of the environmental surface of the COVID care home is very important. Cleaning strategies should be maintained, and the cleaning staff must be protected by appropriate PPE, because you do not know in COVID care home when the people are picked up either from the village level or from the urban level, whether they are COVID positive or negative, and prevent environmental contamination by containing the respiratory secretion, manage the biomedical waste as per the existing biomedical waste management rules. Thank
you. Complete presentation on IPC at COVID care home, and I'm sure you must have taken and revised your knowledge of the infection prevention control at COVID care home, which have already started, and I'm sure you will maintain the sanctity. And like now we are facing problem in hospitals. Those COVID care homes should not be places for spread of the infection. We should take all steps to contain the infection at our level best, so that the people can remain safe and we can control the infection. Two good things I'll announce. One is SCB has completed 1 lakh testing, which needs a lot of contribution and sacrifice, of which in last 4 months time, when we started 20 to 50 tests per day was the target, and now we have reached 2000 plus tests a day and completed 1 lakh. And major burden of the state testing is done by SCB Medical College, and then this webinars and virtual programs all are streamed in the YouTube, and those who want to see it later also can visit from the YouTube and also refresh your knowledge, whatever presentations are done, and you can get the informations from there. So with this, we'll go to the last presentation, and a lot many issues related to dead body disposal have come up, and the central government, the Ministry of Health and Family Welfare, Government of India, and the Odisha all have issued the guidelines, and there are two types of scenarios in the society. In scenario one, people are very keen to take the body and do the funeral at their end, and they don't get adequate freedom in doing that, so they are not happy. On the other end, people are scared about the dead body and nobody coming and touching, and government and the NGOs are disposing the bodies. So two contradictory things we see in the present scenario, and a lot many questions which is based on emotion and religion and the different sects of the society they have raised. So the clear-cut knowledge regarding what the government guideline at present in the disposal of the dead body of a COVID-19 victim during the pandemic will be talked by Dr. Shikata, who is a senior faculty associate professor in PSM in college, and moving from pillar to post, moving from door to door, moving from containment area to secretariat in doing the surveillance. She is a very active member, very difficult to get her. She has run from her field and recently after coming also completed a theory class and has come here. So let us listen her in next 15 minutes on the dead body disposal. Dr. Shikatana.
Thank you, sir. So good afternoon, everybody. A hot topic about disposal of dead body. Now, the main driver of transmission, as we all know, in COVID-19 is droplet infection. Now, it is known that lungs of a dead patient who has suffered from COVID-19 has to be handled properly in case we are doing autopsy. Now, the basic standard precautions that needs to be followed by the healthcare workers while we are handling any dead bodies of COVID-19 is hand hygiene, number one. Number two, PPE, personal protective equipment that consists of apron, which is water resistant, gloves, masks, and the eyewear. And of course, safe handling of the sharps. Now, there is increased chance of this COVID-19 infection from a dead body to the health workers or to the family members in case we do not follow the standard precautions. Now, besides this, disinfection of the bag which houses the dead body and then the instruments and the devices of which is used to the patients that need to be disinfected, and at the same time disinfection of the linen, the environmental surfaces or the rooms which were in which the patient was kept. Now, above all, training on IPC protocol has to be done, starting from the isolation area, the mortuary, the ambulance, and those healthcare workers who are working in the crematorium or in the burial ground. They all need to know about the basic IPC practices. Now, how do we remove the body from the isolation room or from the area? Now, the healthcare provider who is providing healthcare services to the dead body should perform, first of all, hand hygiene, and proper use of PPE should be done. Now, they have to use goggles, the N95 mask, the gloves, and the water resistant apron. Now, all tubes and the catheters, all the plastic drains from the dead body that needs to be removed and that needs to be segregated at the point of generation into the red plastic bag. That is, red is for recyclable plastics. Now, if there's any puncture hole or any wounds that has resulted from the removal of the drains, the tubes, or the catheters, they need to be disinfected with 1% sodium hypochlorite solution, and then we need to dress them with impermeable material. Now, while handling the sharps, for example, if we are removing any IV catheters or any other devices which are sharp, we have to be very careful, and it has to be disposed of into the PPC or the puncture-proof container, which is white in color. Remember, we have to plug all the orifices. Take, for instance, the oral or the nasal orifices, because that has to prevent any leakage of the body fluids from the dead body, as it will contaminate the surroundings. And in the Ministry of Health and Family Welfare guideline, which was issued in the on 15th of March 2020, it was written, if the family members wishes, they could see the body in the isolation room. But that has been changed and not accepted by our state government. Now we have to place the dead body in the leak-proof plastic bag, which has to be, and the dead body has to be decontaminated with 1% sodium hypochlorite solution. And then again, if the mortuary sheet or any sheet is provided by the patient's relatives, they can be wrapped around the dead body. Again, the exterior of the body can or the body sheet, that can be disinfected with 1% sodium hypochlorite solution. Now, the linen which was used by the person who died due to COVID-19, that has to be handled with standard precautions. Like I said earlier, in our previous webinar last week, we had told that it has to be disinfected and then put into the yellow bin. And then again, the bag needs to be disinfected on the outer side, double layered body bag with sodium hypochlorite solution. And any equipment that was used, that needs to be autoclaved
or again, and again it needs to be disinfected. Now, all the medical waste that were generated during the course of treatment needs, if left over, needs to be disposed of in accordance to BMW Rule 2020, the latest version which had come out on 20th of July. Now, the health personals who were handling the body, they need to wear PPE, and then even after removal of the PPE, they need to perform hand hygiene. Now, the family members' counseling is of utmost importance, because during this crucial period, they need to respect the sentiments of each and every individuals. Now, besides this, the environmental cleaning and disinfection plays a major role. Now, the dead body in the isolation area, once it is removed from that isolation room, we need to clean all the surfaces, that is the floors, the walls, the roofs, and the IV stand, the tables, the railings, with 1% sodium hypochlorite solution, and allow a contact period of about 30 minutes, and then we allow it to air dry. Now, ideally, we should not go for post-mortem examination. However, handling of the dead body in the mortuary, embalming is strictly prohibited, and dead bodies can be stored in cold chambers at 4 degrees centigrade. And then after removing of the body, again, the chamber floor, the handles and the floor should be cleaned with sodium hypochlorite solution. Now, in case you are doing an autopsy, a proper precautionary measures has to be adopted. Very few personnels should be allowed to enter, preferably 1 to 2, into the autopsy room. And then the team should use again full PPE, and rounded scissors should be used, and heavy duty blades with blunted points should be used. One body cavity should be dissected at one time, and negative pressure should be maintained in the mortuary, because aerosol generating procedure cause a lot of transmission of this virus. So we have to be very careful, and there should be no reseeding in case they are collecting any body fluids. So as far as possible, post-mortem examination is avoided. Now, transportation of the body is from the when you have secured the body and into the vehicle, and then after removal, you have to follow the standard precautions like gloves, masks, and then sanitize the vehicle once the body is removed from the vehicle with 1% sodium hypochlorite solution. Now, when you're transferring the person from the vehicle to the crematorium or to the burial ground, as per the religious belief, we have to provide information to the ground staff regarding what is the risk that is posed on the individual in regards to COVID-19. Now, the staff should follow standard precautions of hand hygiene. They should religiously use mask and gloves, and at the same time, you can allow the, at least in Orissa, we have up to 3 individuals from the family members or the relatives. They can be allowed to go to the burial ground or to the cremation ground, and they can see for the last time the face of the dead body by unzipping the face. However, no hugging and kissing is allowed. And then religious rites based on the religious scripts or sprinkling of the holy water can be allowed without touching the body. And the body in Orissa is not allowed to be handed over to the family members. And in majority of the cases, it is seen in 85 to 90% of the cases, they give an undertaking, they do not want to take the body, and so it is disposed of by the municipal corporation. Recently, our additional chief secretary has issued an order of payment of rupees 7,500 from the CMRF fund to perform the last rites, and it is based on, and the last rites are performed based on the religious belief of the individual. And the ash, of course, it doesn't pose any risk, and it can be collected by the individuals. However, we have to stick to the norm of standard precautions, maintain social distancing, and as far as possible, minimize the number of individuals who visit to the cremation ground or to the burial ground. So, thank you very much.
Thank you, Dr. Shikada. That was in brief, very well covered about the dead body guidelines, and recently there is a humanitarian touch to the dead body disposal that the family, what Dr. Nanda told, that the family people will be taken into to the function, and even a financial grant has been given by Honorable CM. And the most important thing is that if the party doesn't take the body, it's either a burial or a cremation. But if they want to take as per their religious belief, it can be done with the government guideline. But they can participate maximum 20 people with proper precaution, whatever is safe for them. So with this, we have come to closure of this webinar, and we'll again come with newer topics. I invite Professor Patnaik here, Professor Rautray here, Professor Pani here. And we have very interesting questions, and I'm sure there will be many more questions. There will be many more questions, and the most important question points to Professor Rautray because he started.
Before going to this question answer, I have a query to Professor Rautray. So if a patient is developing hypertension during the COVID-19, can I start a SC inhibitor?
Actually, we can start SC inhibitor. According to the guideline, all the guidelines now say SC inhibitor, the number one drug. The first line of treatment, SC inhibitor, ARB, plus calcium channel blocker or diuretic. So we can start the SC inhibitor. And particularly important, if the patient is continuing SC inhibitor for a particular reason, need not be discontinued, particularly if the patient is having heart failure, then chances of deterioration of the heart failure.
Question go.
Sure. That's the just to give the message. Sir, the few important questions which have come directing to you is the one is management of cardiogenic shock. Suppose a COVID patient, what is the probable pathophysiology? Say patient may go to cardiogenic shock, and then how to manage the shock in the ICU.
So, main important pathogenesis of cardiogenic shock in this patient, as I discussed, this is one is myocarditis, then your vasculitis, which is secondary to either direct viral infection or secondary to cytokine storm. All these things lead to heart failure and cardiogenic shock. Actually speaking, this cardiogenic shock to be treated in the same manner as if patient is COVID positive or not. In these patients, it has been seen dexamethasone has been found to be helpful, but they have to be treated in the same manner. Particularly, you have to give pressure agents like idobutamine, dopamine, noradrenaline, and if the patient is having other is already having respiratory problem, most of them do have an on ventilator. Then according to ventilation and other assisted ventilation and other supports have to be given.
Sure. The other question was, what is the incidence of heart failure in COVID-19? Yeah, that's very difficult to, because I don't think latest data is available. But here also asked the treatment of heart failure in diabetes.
In that expert,
actually,
10% is more.
Yes.
10%.
So actually, this heart failure, what happens? No, that is actually total
cardiological involvement 10% having heart failure.
But again, there is no definite data because all we see, we are those hypothesizing everything, and all are observational retrospective studies. Unless there is a prospective studies taken up, we cannot say, because sometimes many findings are similar because of respiratory involvement, and patient is already having other problems also. So that's very difficult. AKI and respiratory problems, and it's difficult to say. This is a multi-systemic involvement.
And somebody has asked that treatment of heart failure in diabetes along with COVID, diabetic with COVID and heart failure will prefer ORNI or will prefer SGLT2 inhibitor? He asked.
Listen, but I think once the patient is already in COVID, heart will have to treat the COVID. COVID is the cause of all these things. But along with that, you see, if the patient is presenting with failure, is acute heart failure. We are meaning that patient with COVID, patient with acute heart failure. In acute heart failure, there is no question of giving ARNI or your SGLT.
It is all like even iron drops like dobutamine.
Dobutamine, diuretics, oxygen,
all those some ventilatory support, NIV, all those things.
Yeah. This only arises if the patient is already having heart failure, is stable at home, develop COVID-19 infection, and can be treated at home, then the patient will be continuing this same treatment will continue. But if the deterioration, if the reduction of blood pressure, foreign BP, we have to hospitalize and all these things have to be discontinued. Again, we have to reinstitute other sort of treatment.
Sure. Very rightly said. Then we will come to.
Sir, one question. I have got one question.
Yes.
Sir. Sir, regarding the new nomenclature, that is multi-organ inflammatory syndrome children, that a new company that is occurring less than 21 years, there is a post-inflammatory syndrome. After COVID inflammation is completed, then this syndrome is presenting as a multi-organ failure. And most of the failure is a cardiac failure. 80% is having the cardiac failure. And they have seen, they have did the angio, they have found that there is a multiple microaneurysm in the coronary artery. So how will you attribute to this aneurysm?
This is very correct because like this is a Kawasaki syndrome.
Yes, Kawasaki syndrome.
Where we find multiple aneurysms. This is actually because of this direct viral infection. There are three. One is cytokine storm, direct viral infection, and there can be secondary to hypoxemia and all these things. But because of direct viral infection, there is patchy vasculitis. When there is patchy vasculitis, in those areas we will get gradually aneurysm formation occurs. But if there is a diffuse vasculitis, they usually because irregular arteries become irregular, they are also prone to develop thromboembolic phenomenon, even thrombosis. So that's why we don't give this antiplatelets and other drugs.
So, is there any role of aspirin in this aspirin apart from other drugs?
Yeah, you are right. Because theoretically, hypothetically, they have thought in where there is a cytokine storm, when expecting, you have to give give aspirin and statins.
Yeah.
But there are no prospective studies, no studies are not there. But they have hypothesized of giving, and that even in certain cases, a benefits have been found.
Yeah,
benefit are found in hypoxia patient on aspirin, definite benefit with oxygen supplementation and blood thinners. They are telling blood thinners, aspirin. And those will go to ICU, start with enoxaparin, stop aspirin, give and total anticoagulant.
Because the multiple mechanisms involvement, you will have to give.
So regarding this, I will ask one question.
Yes.
So, how many days you will give blood thinning agent? Whether continuing during treatment or post-treatment?
No, that is $1 million question. Those who survive, they have to continue. They have to continue, but duration I do not know, and the studies are not there. But they have to continue for a longer period.
Yeah.
Definitely,
people need to be followed.
Yeah.
Because it's hardly we have 5-6 months experience.
Since we are seeing that post-influenza syndrome can continue for years together.
Yeah, sometimes we have seen that discontinued, there can be sudden death. It is occurred. There may be
that's right.
sudden.
Because there is always injuries there.
Some patients are going from discharge from COVID as well. After 2 days, succumb to death.
Yeah, this may be
so
sudden.
that part also you have to take part very seriously.
Sure.
What to do for those patients who are discharging the patient,
Sure.
but we are not thinking of that part.
Sure.
Whether thromboemboli is occurring and other properly we have assessed and all that.
If other risk factors are there, suppose old age, diabetic, dyslipidemia, will continue with this.
That's the
Actually,
message.
that is one. Other risk factors are there, comorbid there, we are
Yes.
continuing.
Yeah.
At the same time, during the hospital, such things are not there. or during hospital stay, there is finding suggestive of vasculitis, and patient is improved, they have to continue.
Yes. So that is they have added CRP. CRP one important in common test. CRP one important marker to say patient is on, inflammation level is higher.
Inflammation is continuing.
It's continuing. So for them, they are adding. First, you think of giving steroid first. So if CRP level is high,
because it's a strongest anti-inflammatory, and if there is a scar or if there is an injury, maybe only after 7 days or 14 days it's not adequate. You have to follow them for the markers and also for the treatment inhibiting the inflammation, ongoing inflammation.
For longer, steroid cannot be given for longer period, that accelerate fibrosis.
Yeah, regarding aspirin.
Yeah, aspirin
to be given.
Actually,
if you see ICU period or in a hospital stay.
If you see in conditions of vasculitis which is not due to COVID, due to other conditions previously, there are studies giving aspirin up to 2 years.
So you can use aspirin for a long time. This message should go to the
those during the admission has evidence of assault. Evidence of
evidence suggestive assault. Right.
Even in this regard, I will tell, even if we cannot, we are very light about the mild cases. Even what study has seen recently, they have shown that even the symptom, mild symptom, patient is continuing with the symptoms for 3 weeks. So you must be very cautious with up to 3 weeks of those patients. Sometimes mild symptoms were discharging and patient are going to the home and suddenly they have got some.
In fact, that's happening. A lot of you are people going and dying.
That 30% cases of the mild cases are also in this way also they are presenting.
That is again everybody will agree. There are no definite parameter to suggest which patient is going to develop, which mild patient is going to develop moderate.
If that can be detected, then we can categorize those, segregate those patients, and we can take
depending on the evidence, we can put it in the guideline that for the benefit of doubt, they can be given for this maybe 2 to 3 weeks or 4 weeks. These medicines like statin, like platelet aggregation.
You can also observe the patient for this by video conferencing. All those places also can follow.
Especially diabetic, those who are at higher risk, hypertensives, and they have already high risk of metabolic assault, they can be given. So
actually, not 2 to 3 weeks. If we want to give, we should give 4 to 6 weeks. Because,
minimum 4
to 6 weeks. Because even in situations not COVID, but this acute inflammation persists in the vascular level for longer period.
Sure. And you have clearly shown those who are presenting with acute coronary syndrome, whom to intervene, whom to not to intervene, and where to go for conservative therapy and where to. So this is very important when a cardiologist decides how to go about in such a situation where everybody is presumed to be positive. And that's very important. And we are testing everyone, but still antigen test is not adequate. We have got many people negative in antigen who are coming with RT-PCR.
Yeah, regarding this, I will tell management of the COVID is a multidisciplinary approach.
Yes,
only not a single department or single approach is not the actually proper use. It should be a multidisciplinary,
and all have to come
because it involves multi-organ.
Systemic inflammation.
Systemic inflammation involving in multi-organs. Yeah. So it is a multidisciplinary approach.
Like the other day, Professor C.R. Kaur was there. He was telling the facts about the kidney.
It is quite common because this enzyme present mainly in the lungs, heart, and kidney.
Yeah.
Also in the endovasculature.
So in this, I'll ask a question to Professor Patnaik, because there are some doubt regarding this screening. There are some questions regarding screening. Screening means we are doing antigen test for screening, but negative is not negative, and we are getting people who are negative for antigen taken to the ward, taken to the treatment in the non-COVID setup, and again symptoms persisting, repeated with RT-PCR positive, and by that time you are quarantined. So how to?
So in one sentence, I have told previously that 20% are the super spreader, 70% are not spreading the disease, and 10% want to spread these diseases. So regarding this 20% of super spreader, they are attributing 80% of her disease, of the infection 80%. And more characters of this 20% super spreader, there are usually asymptomatic. They are usually asymptomatic, right? So to pick up this asymptomatic group, you require more number of tests, which will be very easy, no technicality, and there will be cost also very less, and which can be done frequently. Suppose one example I am giving. Suppose we are starting schools. What should be our aim? Because as you know, contact, if coming to the contact, there is a intimate contact, close contact, and casual contact. So if a teacher is infected, there is a teacher and under one classroom there are a lot of students out there. All are intimate contact. Suppose the teacher is affected, then everybody will be affected in that risk, right? So today who is coming negative may be coming positive tomorrow or day after tomorrow. Because as you know, the test positivity depend upon the viral load. If viral load is low, then the test does not detect the patient to be COVID positive. This may happen after 2 days, the viral load is increasing. That's why when you're doing the third day, fourth day, or fifth day test, they're coming to positive. And in the meantime, he has infected a lot of people, right? So to prevent, we cannot now, if you today's standard in America, they are doing daily test is 7,50,000. Test is being done in America. 7,50,000. Out of that, 50,000 are positive. Right? So still there is a lot of gap. They are not detecting. Only we are detecting 60% by your RT-PCR. Another 40% are there which are not there, positive cases, but not being detected. So what to do for these 40% cases? So this again, they are working, American people are working, that if you point, this is our point of care test. We have to develop one test which everybody's test. Suppose like pregnancy test. You are keeping a one stick, putting in the body fluid or urine, and there is a color change, and he knows that I am having. If there is a color change and test is positive, in that case he knows that I am positive. So he will isolate himself.
Sure.
So till that, the world is not coming to this situation.
There is another question to you
regarding
that. Somebody has asked about the newer testings.
Yeah.
He is told there are testings proposed from saliva, testing proposed from the cough, type of cough. Even the dogs are employed to smell the sweat of the person, which is specifically they are having COVID-19.
So this is a writer more of the subjective. So I am telling you about the find out the objective test.
Objective test, yeah.
So these are all subjective.
Immunofluorescence.
Test immunofluorescence antibody also is there.
Using artificial intelligence
Yeah.
to interpret the cough. Then we'll say this is corona cough, or this is tuberculosis cough, or this is flu cough.
No, classically we teach a different type of bovine cough. That is a classical teaching that this is this type. If coming from the trachea, this is type. Major airways, this is type. Usually when it affects the airways, large airways, from the cough you can suspect the patient is having bovine cough. That can suspect it. But we want a definite test, which is very easy, will be easy
and
low cost,
in the mass.
and patient will and everybody will have that stick test will be there. If that part will reach, then everything will be changed. Then we can control our pandemic. But this artificial is not enough to control the pandemic.
Because this is a high-end test and it's very difficult to do, difficult to collect the sample and difficult.
And also, so many you are getting report 3 to 7 days. So
by the time there are so many
lot of infection will be there.
So there are many questions related to plasma therapy, but most are already answered by Dr. Parija. Just I'm touching upon few questions. there is a question regarding testing.
Yeah.
There is a question regarding the testing of the donor. Yes, the donor is tested as per the protocol. Maybe the questioner is worried that while discharging the people are not tested. So while screening for the donation, are you testing or not? Yes, they are tested negative, and in our protocol it is there. And that
And what the question is? Why they are not?
Whether the person, the donor is tested for
Before giving
COVID-19
Oh,
adversary
yeah,
or not.
he will be tested.
Tested.
Yeah.
They are tested because
Yes,
they are telling that while discharging they are not tested.
not testing, but
While collecting the plasma.
because the antibody is developing 3 weeks, 4 weeks.
Yeah.
So it is better to 28 when you are calling the donor and on the 28 days, and then we are testing if he comes negative, and if there is a adequate amount of antibody, that one is 640. 40
antibody
should be high. One is
Collected.
640. Then you are collecting.
Yeah.
If other condition does permit.
Titer should be at least 1:640.
Yes.
And you have
Antibody
already
titer.
discussed what are the which condition we will accept the donor, that there must not be a refractory hypoxia during the treatment, and then no septic shock during the treatment. That's all guidelines are there, so we can just obey the guidelines.
Next was
Can a healthy donor with the adequate antibody titer?
Can plasma be given to a patient with renal dysfunction and evidence of hepatitis?
Before that, I will also tell one thing. What the data shows that.
Sure.
So those having symptoms, they have better antibodies than who are the asymptomatic. Suppose patient is, you take a history, you can add one point in there. If patient is asymptomatic, you may not take them if their antibody is not so high.
Sure.
Rather, you are symptomless. That means in symptoms there is an inflammatory reaction, and more of the antibody will be there.
Yes.
Those patients will be ideal for also clinical history should be added in that guideline.
And maybe those who have severe disease has better level of antibody than those who have mild disease. So they have asked patient of renal and hepatic dysfunction can receive plasma or not. He can receive as per the fluid permissibility of the person. And then somebody has asked renal transplant recipient. Somebody has received a renal transplant. You can infuse plasma therapy or not. He can be infused. And somebody has asked one unit caters to how many patients? We collect around 400 ml. It's catered to 2 patients. And grouping and cross matching is done. I have shown you how it has been given to different centers based on their demand. And somebody has asked in patients of it's a very hypothetical question. In patients of reinfection, suppose somebody is discharged and having a reinfection, in that case, what is the role of plasma therapy? Sir.
So regarding the reinfection, because you are telling that after 10 days you are being discharged, initially you are positive and discharged from the hospitals, when you are again testing, symptomatology is there and the RT-PCR is positive. Practically, the virus stays up to only 9 to 10 days. It is culturable up to 10 days. After that, you got a dead virus. If you test the RT-PCR in the dead virus, it will come positive. So not necessarily all the tests positive after 10 days is due to alive virus. It is mostly due to dead virus. So reinfection is not a possibility.
So very rightly, Professor Patnaik has made it clear. The replicability of the virus is only 9 to 10 days, and thereafter there is dead virus, and up to 30 days, this dead RNA can give a RT-PCR positivity. And so this is, you need not be worried about the reinfection. It's at least you are lucky that it's not a problem now. So we have questions to other 3 speakers. They're very important questions to Dr. Thatui. So Dr. Thatui's question is a very interesting question. All the drugs, including paracetamol and hydroxychloroquine, is controlled by the government. How come the remdesivir and the favipiravir is available in the market and common people are purchasing and taking in the black marketing?
It is not, data is not with me. It should not be.
Yeah.
It is regulated thoroughly. It is being dispersed by the designated hospitals, particularly those who are treating COVID cases.
Yeah, to my knowledge, actually, Professor Patnaik
Yes,
also
I'll
knows,
tell.
yeah.
I'll tell. Regarding remdesivir, we have seen the scenario now. You are going to a black market. So if you
60,000.
see the scenario of H1N1 in 2009 and after that, the Tamiflu tablet is also black market, right? So what do you use? Remdesivir. This is my request. Don't use it in every cases. Remdesivir is a offline drugs, off-label drugs, so don't use in every cases. Rather, I will tell if a patient is hypoxemic
I told you. They did.
and you are adding the corticosteroid, and a patient is there any associated with a pneumonic shadow? In that condition, you add it remdesivir. So hypoxemic and
Hypoxemic
and there is a radial shadow.
Shadow.
Add remdesivir.
Yeah.
And usually patients admitted in ICU setups, because remdesivir has its own side effects. Liver enzyme in big issue, so it should not be given outrightly. That is one point. And it's given in COVID positive sick patients admitted in ICUs, not in general ward. You will start giving remdesivir like malaria treatment.
Not for protection also.
Yes, also not for protection also. That is the thing. And it's a trial is going on, not yet been proved. Yes, some hospitals in what happened in Maharashtra, they have opened anybody in any ICU, they are using remdesivir. That is why that is become black marketed. But in Odisha, it's not the scenario. The first treatment, rather, it's the third line treatment. I will say, it's my opinion. I think Professor
Yes.
Patnaik will get. So first, take care of oxygen. First, take care of dexamethasone, simple steroid, dexamethasone. Then oxygen. If requires high flow oxygen with reservoir mask, and the enoxaparin or aspirin in ICU, better to give enoxaparin instead of aspirin. In ward with steroid, one can give aspirin. After steroid, after enoxaparin, if sir has told the pneumonic shadow is there, patient needing high oxygen, patient needing ventilatory support, then one can think of giving remdesivir. It's not outright.
Yeah. That's true.
I think I will tell one regard, because once the patient is put on the ventilator, there is a little role of the remdesivir.
Yes,
Right.
and also
Yeah.
in
So-
ventilatory patient remdesivir.
There is a little role. And in this regard, there are some protocols, some study are there. They are telling that if the patient is on 3 or more liter of oxygen and his saturation is less than 93%, start remdesivir. Steroid not responding, add remdesivir.
Yes, add rest with steroid, add remdesivir.
Yeah.
With
Oxygen-
steroid and add remdesivir.
Oxygen, opening postural therapy, corticosteroid like the dexamethasone. If not responding, is less than 93% with the 3 or more liter of oxygen, add remdesivir. This should be clear cut guidelines.
So
of the
the take home message is oxygen. It go for at least 5 liters per minute.
Yes.
With that, awake proning very important.
Yes.
Then dexamethasone, not very high-fi steroid or like will go for solumetal, etc. Dexamethasone has well proved. The trial
And
has
it is a
shown
6 milligram daily,
daily.
not 8 milligram 8 hourly. It is 6 milligram daily. Remember that.
Dexamethasone. With that, enoxaparin.
Yeah. That is very important. Even I will recommend, not in the ICU, before that, if patient is sick with a hypoxia not responding to the corticosteroid, start enoxaparin.
Enoxaparin.
That is the
Yes, enoxaparin. And after that, we can think of giving remdesivir. One can ask me whether we will go for IL-6 inhibitor tocilizumab or not. That is the point of discussion. Professor Patnaik will say. In
Okay,
cases
if
of cytokine
you
storm,
are doing, as you know, in those cases on 5 to 7 days, the patient is symptomatic, the seriousness develops. So in those period, every day we do the CRP, right?
CRP is
And IL-6 also is there. If CRP doubles is the more than 200,
150 above.
150 above, and IL-6 is increased, then there is a recommendation of
Trastuzumab.
right?
So
It is an off-label drug.
yes, off-label drug. It has its own side effects. It potentiates more infection.
Yeah.
Availability is an issue. Cost is very issue. So take care of all those things.
Another thing is remdesivir. Suppose now in COVID time, we are seeing a lot of patients coming with the tuberculosis, or in the tuberculosis patient, there is a COVID,
Yes.
right? So they are on anti-TB drugs. Here, as you know, the remdesivir, when you are using parazinamide, there is causes more toxicity. As you know that this is hepatotoxic drugs. OTPT is rising less than 5 times, you don't give.
Yes.
So when you are giving anti-TB drugs, especially parazinamide, it interacts with and it potentiates the hepatotoxicity. Very cautious when treating with the tuberculosis and with the remdesivir.
Remdesivir together, antiviral and antitubercular.
And another thing is favipiravir. So don't use that. You are using past is like a oseltamivir. So it is not a tremendous drug.
Yes.
It is a off-label drug.
Yes.
So there is and more number of tablets.
Yes, I told you.
And cost of treatment is high,
Very high.
without any effect. So there is every chance that there is a black market in the market that was
already there.
market. So what I recommend that this is not a very good drugs in that way. So don't be panic of taking drugs or blocking the drugs. As the market will there, the price will be high. So nothing.
So maybe the take-home message is oxygen, awake proning, steroid, enoxaparin.
And if you at all want to start early.
Yes.
In the last stage, there is no role, and maybe they were more toxic than good, and may not help in management also. So if you think that these are older drugs and it can only save the life,
not a wonder drug. So regarding the plasma, when do you start the plasma? That is also very million question, right? Because when the patient is already in the ventilator, he has developed his own antibody, right? In that time, if you give antibody, you can revert the things. Because what is happening is due to his own antibody, right? So ideally, plasma will be before going to patient is sick, very sick, not responding to any therapy, whatever we discussed. And before putting the patient in the ventilator, if you give the plasma, definitely it's
First week. It's better in first week. It's a first week because in second week, in the patient himself, the antibody letter rises. So it starts within first week.
So that's very important. The ideal is failure of oxygen therapy, failure of dexamethasone, you think of plasma. So when initially they fail, you think of plasma. If patient has gone to ventilator and patient has gone to shock, rather that is contraindicated for plasma therapy. So the P/F ratio less than 200 and patient in shock is a contraindication for plasma therapy. So the last question to Dr. Thato is about again somebody has asked about the Umifenovir. There is an antiviral drug.
Yes. This is on trial. These drugs are on trial. Studies are not there. Maybe some off-level, open-level studies, anecdotal data. There is no, we people, we believe on robust data, RCT trials. So these drugs are not in the RCT trial.
So it's over. Regarding the drugs, my question to Madam Nivedita ma'am, who told very nicely about the infection, infection prevention control. Somebody has asked that, Madam, you have spoken regarding the COVID care home. So how COVID care home are different from the COVID hospital or dedicated COVID hospital center? So what is the level of care given in COVID care home, And why IPC at COVID care home is different than that of the COVID care?
Actually, COVID care home is being done in the village level and the urban level, where from the beginning, say people will picked up, and with any ILI like fever, cough, and cold, they will come to the COVID care home. In the COVID care home, they will be given test will be done. How many people will stay? 10 to 20 persons will stay, and there it will be screened out who are positive. Who are positive, they will go to the either to the COVID care center or to the COVID care health center or to the COVID dedicated COVID hospital as per the symptoms. And in the COVID care home, once it is negative, either they will stay there till the symptoms decreases or they can go home. And the IPC, if you see, it is more or less same, but here this is managed by the mainly by the administrative managed here by the Panchayat Raj, like all the local authorities, ANM, medical, MPSC, medical supervisors or the doctors. The only that is doctor will not be present there. Doctor will come and supervise a thing. Who will work there? They are the ANMs or the like this which I have told you, the basic health workers or the ASA Karmis. They will screen out. It is a more or less a screening center. From there they will find out, and whoever little less symptomatic, they will stay or go for home for if that is for quarantine. But here in the dedicated COVID hospital, if you can say, it is a big hospital setup with ICU setup. All the complication patient is handled there. And as for the IPC, if you look at here hardly 5 to 6 instruments has been used, which I have told you, BP and all the thermo like temperature regulator or the what is that called, thermometers, then BP cough, then all these things, heuristics. But in the COVID dedicated COVID hospital, they're all the ICU, so all very high profile materials are we use. So definitely the IPC for these small things and the bigger thing will definitely it will be bigger in the dedicated hospital. Here it will be lesser. Here with, if you can watch here with the hardly pulse oximetry and all this, with the alcohol we can sanitize or what we can decontamination, whatever it may be. But COVID hospital, there the IPC is being more troublesome, and there will be one nodal officer will be there. Here it will be managed by the local level. It is not so like high-handed thing, but same protocol of the IPC will be same. I think
regarding, I will tell. So,
waste management is
almost same.
The difference you will put in a COVID care home, you will have atmosphere municipal black and the yellow, and in COVID care centers, because we have staff nurse there managing also, doctors also.
So it has got 2M. So number one is the decentralization of the service. So now how at the grassroots level people get the service, the government is decentralized, and it's a one sort of the isolation.
Screening sort of.
Isolation and to segregate those group of the ILI and group of the SARI group. We are isolating. And we are also, that is also screening. It is one of the sort of a screening, we are doing the screening.
Yes. Thank you, ma'am. There is another question which has come now. Maybe Professor Patnaik may reply that. Is it essential, good evening, Sas Madam, is it essential to hospitalize an asymptomatic COVID positive patient from the beginning?
No. So as you know, government of now Odisha has decided that less symptoms are asymptomatic patient to be home isolated. The term is home isolated. But in this regard, I will give a point, because from the test we know the CT numbers. CT number shows the viral loads. So patient is having a low viral load, we may isolate in the home. Patient with a high viral load or moderate viral load, we can also keep in the hospital. High viral load we can keep, because the complication is more in case of the high viral load. Like we are sometimes seems that it's like a thromboembolic phenomena, suddenly patient crushing. Those patients can also, high viral load, they can also keep in the home.
So if we give a criteria
viral load.
to decide home isolation or the
Yes,
institutional.
because that will be the.
It is not giving
Then the
they are
city
not
number.
giving 17 to 35 to 40 से जो रे super spreaders और ये हमें advisable is not giving.
Not giving, but tomorrow may
Yes,
happen.
may.
So we might be very cautious about this high viral load patient.
Yeah, so the final questions to Dr. Shikata. She has spoken a very important topic today, and lot many discussions are there. Lot many questions Dr. Parija has answered, and this is very important question that COVID. Can we confirm the COVID status after death of a patient? So somebody has given a scenario that a 50-year-old person has died in a containment area with history of fever for 3 days, never tested, never reported to hospital. In a suspicious situation, the patient had died, came in contact with many people. So can we test after death the COVID RT-PCR? And second question, how long the test can be done, and how we should move about in that.
So whatever the recent guideline is there for dead patient, there is no test. There will be no test. Right? From dead body, you cannot take a test and do the test. And regarding the patient, if he is dying and you have sent the test, you have to inform the lab that patient is dead. No test will be done in that patient. So all the patient with this SARI or a suspected COVID should be treated like a COVID positive person.
So that is the answer. You have to presume.
Yeah, presumably this should be treated. Guideline says that
dead body should be disposed
as per the guideline of the
COVID-19 patient, and all contacts should be quarantined, tested. As if the patient is COVID-19 positive, you have to presume that patient is positive, and no meaning of testing.
So no test is done in the
dead bodies. So that's all about the questions, and I thank everyone for a very active participation. I thank Professor Patnaik for spending his quality hour, almost 3 hours. He is with us. Professor and sir is staying in the campus only. I'm seeing from morning to evening, from COVID ward to pulmonary medicine, from dean office to superintendent office. He is moving around, not taking care of his own health, own family, and personal aspects. So when a huge
my physician is there, my cardiologist is there to take care of my
I know how much he is motivated in this pandemic, just to forget everything and to work for the cause. And Professor Rautrai is here, and lot of congratulations has come to Professor Rautrai. People are very happy that he has spared his valuable time and he has covered pathophysiology of cardiac involvement and also the heart failure, ACS, as well as the hypertension management, the confusions regarding ARB and ACE inhibitor. He has solved that, and he has also told good wisdom regarding the antiplatelet therapy and the low molecular heparin therapy. So these are very important aspects in the management, and I'm very happy that he could give this quality time, and the whole team could take up many questions, especially and Professor Patnaik took many questions from his side to get it clarified for you all, because they are genuine doubts of everyone. So I thank Professor Rautrai, thank Professor Patnaik. Professor Pani is always there with us, and she will go now to Bhubaneswar, long way, but still takes the occasion to speak you on any topic which we assign her, and she takes up in her interest. We see how meticulously, as a policy maker from COVID care home, he has taken detailed classification and meanings, which many of you must not be knowing by now, because it's a new concept. The concept of our Honorable Chief Minister that COVID care homes will come up with the concept of keeping more patients, because the problem will stay with us for a long time. We have Dr. Shikata, who has, I told, come from the surveillance, come from the class, and covered the dead body policies very well. Dr. Parija has given you the link, and for your doubt, for your to pass on the information to your known and near and dear one you can see, and it may change from time to time, but this is, I think, very humanitarian and very best on the taking care of the emotion of everyone. It has been designed. And finally, I thank Dr. Thatoi. In a very short notice, he has prepared the two important newer antivirals and told you the right approach to them. And our whole team, including Devashish, Maguni, and Shuraz, and the whole team who have managed today's show. I thank Professor CBK Mohanty, Professor VK Dash for inspiring us always. I thank Mr. Rupinder Punia to take the lead, and the Department of Health and Family Welfare to provide the opportunity to interact with Evolve. And I'm sure in this week and coming week, we are coming with much more newer topics like nutrition, like pregnancy, so, like mask. There are many demands, and whatever things you want, you can give feedback to government, feedback to us, feedback to the whole team, so that we can include those topics and take from time to time. The purpose is to empower all of you. The knowledge is power, and the pandemic is on, and we are not, we will not get rid of the problem very soon. It's going to stay with us for quite good time. So I thank everyone and end today's program. Thank you. Thank you, everyone.